Hi, my name is Jocylin Egan, and I will be presenting a patient who has diabetes mellitus type 2, and at this point he's refractory to treatment with metformin, so we'll be exploring some further treatment options.
Mike is a 56-year-old male. He was screened for diabetes mellitus type 2 6 months ago, and he was diagnosed at this time by his PCP. His PCP screened him due to the following risk factors. Mike is over age 45. He has a family history of diabetes mellitus and heart disease. He has obesity, hypertension, hypertriglyceridemia, and he has a sedentary lifestyle. Upon his diagnosis, he had 2 serial fasting plasma glucoses of 181 and 184 milligrams per deciliter. That's about an 8% A1C level. So this confirms the diagnosis of diabetes mellitus, which requires 2 serial fasting plasma glucoses of 126 or above, or 1 single A1C of 6.5 or above. And additionally, his PCP did a C-peptide test to confirm type 2, and it did indeed come back high. At this time, Mike's PCP prescribed him metformin 500 milligrams twice a day. Mike's first A1C 3 months later was still at 8%. So his PCP continued to titrate the metformin dose up every 2 weeks by 250 milligrams. Now, 6 months later, Mike is at a max dose of metformin at 1,275 milligrams 2 times per day, for a total dose of 2,550 milligrams per day. So currently his A1C is 7.2, and Mike reports no symptoms of polydipsia, polyuria, polyphagia, or sluggishness.
Subjective history. Mike's past medical history includes type 2 diabetes, which we're addressing today, hypertension, hyperlipidemia. He had bilateral knee replacements in December of 2014. He has no allergies. His medications include metformin, lisinopril, aspirin, simvastatin, and multivitamin. His family history includes a father with type 2 diabetes mellitus and congestive heart failure who was a smoker and had an above-the-knee amputation at age 50, so a major complication with diabetes and smoking. He is deceased currently. He died of an MI 3 years ago. Mike's mother is still alive and has controlled hypertension, no other medical history. Mike is married with 2 children who are in their 30s. They have a tight-knit family. He's sexually active with his wife, 1 partner, does not notice changes or issues with sex drive, and he feels safe at home. Mike works as an accountant for the electric company, fairly sedentary lifestyle. He walks occasionally after dinner with his wife. He drinks, on average, less than an alcoholic beverage a day, denies smoking. He does have a history of secondhand smoke exposure, and he drinks 1 Pepsi per day. Review of systems. Generally, Mike denies fever, chills, fatigue, weakness, night sweats, recent weight gain or loss. He denies changes in hearing, vision, or headache. He denies gingival bleeding or ulcers. He denies chest pain, syncope, cramping of the legs, or intermittent claudication. Mike also denies shortness of breath and or cough. He has no nausea, vomiting, or constipation. He reports 1 loose stool per day and 4 small stools. This started after he was prescribed metformin 6 months ago, but he had some constipation issues prior, and he feels that he's okay with these GI effects. He denies dysuria, polyuria, urinary hesitancy or urgency, or nocturia. He denies polydipsia, polyuria, polyphagia, so signs and symptoms of hyperglycemia or signs and symptoms of hypoglycemia. He denies paresthesia or numbness, tingling, or burning of the lower extremities or digits. He denies loss of consciousness or fainting. On physical exam, Mike's vital signs are within normal limits, though he is overweight. He's 6 feet tall and 200 pounds, and his BMI is 27. He is alert and oriented, pleasant, well-groomed, and has clear speech. His head is normocephalic, eyes are symmetrical, conjunctiva clear, sclera white, and perla is appreciated.
His visual acuity is 20/30 with a Snellen. His lung sounds are clear, no cough present. His heart has a regular rate and rhythm. S1 and S2 are present. No murmur, rub, gallop. No JVD. And 2+ peripheral pulses. Also, no edema is present. His abdomen is warm, non-tender, and non-distended. All bowel sounds are heard in all 4 quadrants. His skin is warm to the touch without a rash and no bruising. On careful examination of his feet and between his toes, which are warm, there's no evidence of ulceration, breakdown, no fissures or discoloration. We did a neurologic exam on his feet with a cotton wisp vibration and a pinprick, and his sensation is intact bilaterally. As far as lab values, we know his A1C is 7.2 and his fasting blood glucose is 161. I did run a BMP, which needs to be done for someone who's been previously well controlled on metformin. Though he wasn't necessarily well controlled, I still wanted to run a BMP to examine his electrolytes and any potential lactate formation. So all are within normal limits. He has no serum, or his serum ketones are less than 0.6, which is good. His creatinine clearance is 1.2, and his GFR is 62. We did also run a 24-hour albumin to monitor for microalbuminuria, which is less than 30 and is normal. This indicates that he doesn't have any kidney disease. So his kidney function is looking good so far. His ALT and AST, as far as his liver function, are within normal limits, and we want to monitor for this to check his ability to clear lactate. His triglycerides are 148. His total cholesterol is 5.2. And you can see below that, all are within normal limits as far as his HDL and LDL as well. His TSH and T4 are good, no hypothyroidism, and his B12 level is normal as well, which needs to be monitored with diabetics. This is an adjunct slide to the prior, which addressed Mike's lab values. This is retrieved from our textbook, Wu 2016. This is from the American Diabetes Association, and it's the treatment targets for persons with diabetes. We are looking for a hemoglobin A1C less than 7, and within this range, we're also looking for the following ranges of glucose levels, blood pressure levels, the lipid panel, and excess urinary albumin secretion. So that really the key concept to this slide is that these are targets that we're looking for. We need to individualize treatment as well for people, especially in the elderly, children, or pregnant women. We need to be aggressive at the time of diagnosis with our pharmacological treatments of diabetes, because often people are in more advanced stages at the time of diagnosis than we had previously thought, so the risk for microvascular complications is high. As far as the pathophysiology of diabetes mellitus type 2, it involves 7 organs and tissues: the liver, pancreas, skeletal muscle, adipose tissue, brain, GI tract, and kidneys are all affected. The overarching pathophysiology includes decreased insulin sensitivity and insulin secretion. This leads to hyperglycemia. 90% of people with diabetes mellitus have diabetes mellitus type 2. So the role of inadequate insulin secretion, there is a decline in beta cell functioning. So beta cells, normally, the beta cells in the pancreas produce endogenous insulin and respond to high blood glucose levels. This is compromised in diabetes mellitus type 2, and it starts early in the disease process. I want to be clear that DM2 is not an autoimmune destruction of beta cells, as in DM1. In people with diabetes 2, some insulin is always produced, so it's rare to develop diabetic ketoacidosis.
When food is ingested, endocrine cells in the GI tract secrete incretin peptides. GLP-1 normally stimulates insulin secretion by the beta cells and quells glucagon secretion. The regulation of insulin secretion is compromised in diabetes mellitus type 2 due to altered functioning of the enzyme DPP4 that affects the presence and duration of glucagon-like peptide 1 actions. There's also impaired sensitivity to insulin. This occurs in the periphery, in the muscle, liver, and adipose tissue. In the adipose tissue, there's a failure to use glucose in response to insulin, which leads to obesity and also fats in the bloodstream. This develops plaque in the bloodstream over time. In the liver, there's increased glucagon levels, and in the muscles, there's a failure to take up glucose for use in energy production. Diabetes mellitus type 2 can go undiagnosed for many years due to the lack of symptoms, and because of the likelihood, therefore, of advanced stages of illness at the diagnosis, it's now recommended to get tight control over our glucose levels early in the stages of the diagnosis at this point. Hyperglycemia can cause polyuria, polydipsia, polyphagia, and unexplained weight loss or weight gain. These can all occur, but often they are hidden in the disease process and do not present themselves until later, or when blood glucose levels are very, very high. The symptoms of hypoglycemia are shakiness, dizziness, lightheadedness, sweating, headache, sudden mood changes, a lot of hunger or thirst, and confusion. As far as risk factors for diabetes mellitus type 2, genetics have a strong influence. Offspring of parents who both have diabetes mellitus type 2 have a 15% chance of developing DM2. Any one of the 4 clinical indicators of metabolic syndrome is a risk factor. Hyperlipidemia, hypertension, obesity, and insulin resistance are all included. Sedentary lifestyle is a risk factor. Diabetes mellitus itself, 1 or 2, is an independent risk factor for coronary artery disease. And it's important to note that DM2 occurs more frequently in Native Americans, Asian Americans, Latinos, Pacific Islanders, and African Americans. But once diagnosed with prediabetes, all races have an equal rate of subsequent diagnosis. This is the most recent 2017 glycemic control algorithm produced from the American Association of Clinical Endocrinologists. This gives a great algorithm that we have also seen in class, and I use this as far as my avenues for treatment options for Mike and the medications that I present as far as options in the following slides. As far as pharmacological treatment options, I did go by the prior slide, the glycemic control algorithm, and these are all oral agents. I'll briefly go over them, but there's much more detail on this slide. Of course, Mike is on Metformin, which is the first drug of choice in newly diagnosed DM2 patients. Very low-cost drug and low risk of hypoglycemia. GLP-1 receptor agonists. These are given subcutaneously only. They actually help with weight loss, and they're very pricey, over $500 per month. There are DPP-4 inhibitors. So these both GLP-1 and DPP-4 inhibitors work on beta cells. DPP-4 inhibitors increase insulin synthesis and secretion. They're very costly as well, over $400 a month. SGLT2s, they are nephroprotective and cost also over $400 a month. Alpha glucosidase inhibitors delay absorption of carbohydrates from the small intestine, and they lower postprandial blood glucose. These can cost about $30 a month, so they're not too expensive currently. Sulfonylureas are second-line agents just because they can cause hypoglycemia. They're not good for people who are overweight, so they should be avoided in overweight patients, though they're often used as dual therapy with metformin, even in people who are overweight. You'll see this often in practice. Low cost. I can never pronounce this, but thiazolidinones require close monitoring of heart failure signs and symptoms. They can cause fluid retention. There's a lot of controversy over these. Their cost is low. It's $12 for 30 tabs. Metformin is the drug of choice when initiating therapy in diabetes mellitus type 2 patients. It does not increase insulin release, therefore there's no risk for hypoglycemia. Metformin decreases gluconeogenesis, or hepatic glucose synthesis, and GI glucose absorption. It increases insulin sensitivity in the periphery, and you must be making insulin for metformin to work. So the patient must be type 2 diabetic, not type 1 diabetic. Metformin is affected by food intake, so food decreases and delays absorption of metformin. It is 50 to 60% bioavailable fasting, and the peak plasma concentration is 2.5 hours. It splits into erythrocytes, and it's excreted through the urine, 100% unchanged. 90% of the absorbed medication is eliminated via the kidneys in 24 hours. The plasma half-life is 6.2 hours, and the blood half-life is 17.6 hours. The goal of therapy is to lower blood glucose, increase insulin sensitivity. It's to be used in conjunction with other medications to decrease A1C. It can be used alone as well. Its goal is also initially also weight loss, and metformin can reduce the A1C by 1.5 to 2%. We really need a GFR at the initiation of therapy, not to use metformin when the GFR is less than 30. And it's not recommended to even start patients on metformin if their eGFR is between 30 to 45. A lot of caution with use of contrast dyes in metformin, so CT with contrast, you'd want to stop metformin prior to this test. Low dose titration is highly recommended to reduce GI side effects. You want to start at 500 milligrams once or twice a day, then increase by 500 milligrams daily every 2 weeks as needed. GI side effects are substantial in many patients. A lot of diarrhea, indigestion. Also, weight loss is a positive side effect in addition to reduced LDL, total cholesterol, and triglycerides. There's also an increase in HDL. It can cause lactic acidosis, hepatotoxicity, and a metallic taste in the mouth, also headache. So this is why we did a hepatic panel and a CBC at baseline. Monitoring GFR, CBC, and B12 levels. The second medication that I selected is the alpha glucosidase inhibitor Precose, as the brand name. It inhibits upper GI enzymes that convert dietary starch and complex carbs into sugar. Precose delays absorption of carbs from the small intestine and lowers postprandial blood glucose. The cost is $30 for 90 tabs, so it is affordable. As far as absorption, it has a low systemic bioavailability, less than 2%, and acts locally within the GI. And the peak onset is 1 hour, and the peak plasma time is 1 hour. It is metabolized through the GI tract, again, less than 2 systemic absorption. It is excreted through the feces at 51% as unabsorbed medication, and through the urine at 34% as inactive metabolites. It's less than 2% unchanged in the urine, has a half-life of 2 hours. The goals of therapy include to further decrease A1C levels and blood glucose levels. With A1C at 7.2, for Mike, our goal, of course, or for any diabetic, is an A1C less than 7, as long as they're not elderly. So this medication may tip the scale in addition to metformin to lower his A1C. Also, the goal is for weight loss, and this medication will not promote weight loss, but it will not cause weight gain. We need to consider Mike's hypertensive history and hyperlipidemia diagnoses. This medication will not affect either of these. We also need to consider, along with weight gain, that Mike is technically overweight. So it's best to avoid medications that may contribute to weight gain. The side effects include diabetic ketoacidosis, ileus, inflammatory bowel, colonic ulcers, hepatitis, thrombocytopenia, and there's a lot of caution for people with renal impairment. So a lot of GI side effects. We know that Mike is already on metformin. I've done research, and it looks like if people can tolerate both of these medications together, the research says that they can be used together. So I'll further discuss our plan as far as this medication with Mike, but for now, this is the selected medication. The common side effects include flatulence, diarrhea, abdominal pain, and elevated LFTs. You need to monitor creatinine at baseline and LFTs every 3 months for 1 year. The following are my recommendations for treatment at this time for Mike. It is to add Acarbos to his medication list at 25 milligrams every 8 hours with meals. The plan is to have him return to the clinic in 4 weeks to do a 1-hour postprandial blood glucose, and at that time assess whether we need to change his dosing. I want to heavily stress to Mike the GI side effects of Acarbos and have him report anything immediately to me so that we can make a change. I want to encourage increased activity levels, so maybe he can go walking more regularly after dinner, he could bicycle to work. With his increased BMI, I would want to probably discourage running at this time and maybe increase bicycling, as it could have a negative effect on his knees, but really any activity that he desires to do that's more active and brings him joy is very important. I need to go over his daily dietary intake and encourage 60 grams of carbohydrates at each meal, give him resources for carbohydrate counting. I would encourage eating more vegetables, adding fiber to his diet and lean protein, and replacing that Pepsi maybe with a seltzer, as Pepsi will really have a negative effect on his A1C levels. As far as recommendations and medication choice for Mike, this was very difficult because he does have congestive heart failure risks, and he has, because of his father, he has hypertension. So Mike and I would rather avoid TZD medications. He would rather risk the GI side effects of this medication and try it at this time, and so would I. The patient prefers GLP-1 agonists, and we will consider switching to these if this medication produces adverse effects, but it's just a great financial risk to take at this time without trying another agent. If at Mike's 3-month check his A1C is not at goal, we will need to add a third agent. Finally, and very importantly, we need to go over some education points with Mike. Signs and symptoms of hypoglycemia need to be reported immediately. Signs and symptoms of hyperglycemia need to be reported as well, but we need to educate him that these may not occur until his blood sugar levels are over 300 or very, very high. So it's very important to, kind of create a diary of his symptoms and something for him to reflect on and understand if there's any trends occurring. Need to go over self-foot exams with him with a handheld mirror, check for spots, check for ulcers, soreness, numbness. We need to educate him that there's very much so an increased risk of infection for people with diabetes mellitus type 2. So the following vaccinations are recommended: a yearly flu vaccine, 1 pneumococcal vaccine, and then again when he is age 65. I want to encourage yearly dilated eye exams with an ophthalmologist and make sure that we are monitoring for microvascular complications. We need to make sure he goes to the dentist for a cleaning every 6 months and that he brushes and flosses twice per day, as there's a higher risk of infection and gum disease with elevated blood sugar levels and diabetics. We need to, again, as stated previously, go over his physical activity levels and find something that he can add that he would enjoy doing. He needs to drink plenty of water, eat consistent meals, maybe even keep a food diary as well, to monitor his carbohydrate intake, and to report any changes in his urination frequency, or erectile dysfunction. And again, GI side effects, very important for him to report any discomfort. So that concludes this case study. Thank you very much for your time, and I hope that you enjoyed it and learned a lot.